commercials with a certain group of people. And if one does not seem to think that they fall within those realms, that's just disregarded. When we talk about you equals you, just within the HIV positive community, many of those individuals don't even know you equals you, what that means. And so to suggest that clergy would, I'm not surprised. And in the epidemic, we do the EHE, and so we have all these acronyms, and that sits in the place of those of us who do the work. And so we understand what that means, but I don't think even we broadly have not disseminated that information out. Then coupling with COVID, that has taken a precedence. And so when the money came down the pipe and rolled out, a lot of those things were done in ways that was like, let's just get this out as quickly as we possibly can, but still under the radar where everybody else did not know. Or at least that's how it has been seen from my lens, even in our own places of Charlotte, how things are going. So.
No, that's true. That's true. And if it's education may be getting out there, but it's obviously not hitting the populations at which it needs to be hitting, and that's a disservice of the government, right? And part of it's like where are they putting their money?
Yeah.
I have a follow-up. Obviously, I'm not a religious leader, but we're heading the ending the HIV epidemic in the U.S. We work for the Office of the Assistant Secretary of Health. And we've been talking to religious leaders, and my question is, I have a few. One of them is, I saw the states that you're working with. Arkansas is one of ours. We've got 5 states here in the South. What kind of distribution you have between rural and urban areas? Because that is going to vary your response. One. Second is, I see that a lot of the religious institutions or churches, pretty much, to put it simple, they are equipped to really add on to the force multipliers in terms of patient navigators, emotional support, because there's always this continuum where before they get to an actual mental health services provider, they get to the spiritual healing process, and that in turn, if they do the educated referral, they do connect it with mental health services, and that also becomes a stigma. So that's part of what we've been seeing out there, and I was very pleasantly surprised that some of the leadership, they're ready to go. It's just that COVID came up and it's kind of redirected their efforts, and they became just like social transformation agencies pretty much because of homelessness, food pantries, things like that. So it was kind of secondary, even though we call it a syndemic. And we got the 2 pandemics going on at the same time. But I see that it's a lot to contribute and a lot of willingness to do it. And like I said, Arkansas is one of our rural. They get special funding from the federal government because they're a high burden of increasing the incidence of HIV, and they got special funding. But part of what we're finding out and determining is exactly trying to change the funding strategy. And we already created some different funding approaches, and we don't have to wait for 2 years of statistics being vetted. We're giving the Secretary of Health direct, real-time information. They're reacting, especially, and also the CDC. We met with Dr. Vasquez about a month ago, and we gave an entire presentation about our findings through the area, and I'm pretty sure they're going to be taking action. So the other thing is just, and this is not here, not there, but it's interesting. It was very interesting that in one of your pillars, you changed prevention, the prevention pillar that we put out there for protect. And I just wanted to ask a little bit about
I didn't change that. That was just directly pulled from another article. Yeah.
Interesting.
Yeah, so I think it...
Because it's normally, treatment, diagnose, treatment, prevention, and response, and then instead of prevention. Okay. But anyway, that's partly...
No, you're making excellent points. Yeah.
Because if we're going to be, spreading the word, disseminating the information, I think that should have been prevention. And you mentioned it, HIV testing sites. And not only that, I mean, the whole I was part of the Affordable Care Act, under President Obama, and I was handpicked for this ending the HIV because of my experience with Affordable Care Act. I implemented the Affordable Care Act. But the same approach that we use to attack, or get more people enrolled in Medicaid, Medicare under the new Affordable Care Act guidelines, we brought technology and enrollment kiosks to gas stations, religious institutions, so people have access to technology. They would come in and then they would do their enrollment, and the ministers, pastors would help them do that. And that was very successful. Why aren't we taking the same approach to provide that alternative with HIV services? Churches can be of great value, and whether we want it or not, it'll kind of be a decoy to really what their services are for. Because places that provide STI and HIV services, they get stigmatized immediately.
Yeah.
So if you go to your church, no one should care that you're going there for your HIV services through telemedicine. So anyway, one of the many things that we observe in 5 states that we have jurisdiction over, and we're trying to change the map. That's what we're doing.
Absolutely. I will say that I think the folks that we recruited were probably more from less rural areas. So like you think Little Rock or like West Memphis area, not so much of super rural Arkansas. So as someone who is from a teeny tiny town in north central Arkansas, I feel like hitting some of those communities, I feel like you may actually be coming in a different place. So these clergy were more like they were willing to come talk to us about HIV. They enrolled in a study to come talk to us about HIV prevention efforts. Can't say the same necessarily. So we may have your strategies may look a little different. So I should have prefaced that by saying that as well, something to consider. But we do have some recommended, like these are sort of what the clergy mentioned as the strategies that they think would help. And you have already all sort of mentioned a lot of these, which is partnering with healthcare centers. So not just partnering, but one thing that came up was clergy said clinics should come to us. Yeah. The clinic should be talking to us. Like we have so much burden, so many other tasks that we have to do that why not have the clinics come in? Not only to educate pastors and to like inform them, but also be part of the educating the congregation. Bring a nurse in to stand at the pulpit after a sermon and say, here, let me tell you the stats. Here, let me tell you how HIV medications work. They don't want it to all be just on them necessarily, which I agree with. But it's sort of, they want the clinics to come to them, and also, this is a conference in which I'm not seeing any, I don't know, is anyone a nurse here or, work at a hospital? So it sort of is all that to say, sometimes I think thinking through how clergy can create opportunities for themselves, identify clinics and community healthcare, organizations that they can partner with, and like small steps to make big change. So could you contact one clinic, or could you identify one person in your congregation that maybe has the time and effort to do that? And then stigma reducing. So, HIV messages about PrEP, treatment as prevention, you could be bundled with other health messages to reduce stigma. So oftentimes HIV, it's sort of its own package, and they're like, no, like we should, HIV, diabetes, cancer, can we put them all together and talk about them? Or if you're gonna do a health fair, let's do all those together. So you're not just coming for HIV testing, you're also coming to get your blood levels checked, or you're also coming to get your BMI checked. Like, maybe you need to eat a little less, that's what it is, So that can help reduce the stigma. And then they also said that they need ongoing resources and technical assistance. So it's sort of, this is where it's like, well, if you had more resources to and funds, for example, to host health fairs, to identify and maybe even compensate people in the congregation to lead the health ministry, like that would be very beneficial, which makes sense. So and I'll get to, this is on another slide, but I think another important thing that came up was they said, have folks living with HIV or even folks that are at higher risk of acquiring HIV come in and give their, I labeled like their PrEP testimonial. Here's why I choose to take PrEP, right? And they're standing in front of the church as they're saying this, and this is how it relates to my faith. Or someone living with HIV coming in and saying, well, here's why I go to the doctor to take my medications. Here's why I want to be healthy. So, and I think if you can get those folks who talking about it also helps normalize. for example, we just did a study with 30 Black women in Mississippi who are at higher risk of acquiring HIV. They said they want to hear from other Black women about PrEP. We need to rebrand PrEP to be something that's for everyone. Same thing with men. So I have another ongoing study with young Black men living in Mississippi. And they said, you know why people that are on the down low aren't coming in for PrEP? Because PrEP's been branded a gay man's pill. So if we could rebrand it to be for anyone, regardless of sexuality, they're going to be more likely to come in, right? So I think having these kind of conversations, like, and even like adjusting commercials and how we talk about PrEP, it's like. And
adding to that, well, we had one about women in advocacy. There's a Positive Women's Network throughout the nation, and that they connect virtually. They meet bi-weekly. They're all over the country. I wanted to validate your point about women not being incorporated into the initial studies for PrEP. Perfectly understood that why we need also advocacy in that sense. But it is more than just, I guess, a women's problem when it comes to HIV prevention. We have very alarming numbers in Baton Rouge and New Orleans, where heterosexual transmission is almost 20%, when in other states it's 6%. I mean, not 6%, but the ratio is 0.6, which, 6% of the total new acquisitions of HIV, 18% heterosexual women contracting it, acquiring it, is really something that we need to look at. And they're part of our region. And I think the faith-based effort is going to be key in doing something about ending HIV there in Louisiana, Baton Rouge, and New Orleans. And we're just tracking continuously.
Absolutely.
It's alarming.
Yeah.
It's very alarming. However, let me push back. Because here, for me, being the CEO of a community health center, one of the things that we've seen, and I have African American females who work for me who are of childbearing age and who are engaging in sex and who actually are not married. And they know everything about PrEP, but they won't take it. They have decided that that is not something that they need or they want, and knowing all of the things that come with it. So it becomes challenging for my team to even, when we began to talk about, well, how do we then develop some programs around PrEP and women, along with making these individuals feel comfortable. But we also, and I understand about when Gilead were researching and targeting and trying to decide. But of course, we know they decided to do that because it was easier to do it because of men and MSM and getting that to market quickly.
Mm-hmm. Yeah, it makes sense at the time.
It makes sense. However, the other thing to that is that just doesn't mean what it was like, okay, well, because of the absorption of the medication in the vaginal area versus rectal. So all those things came into place. But then the women started screaming then, well, you forgot about us. And so it was like, well, you're not totally forgotten about. I mean, we still have a medication for you. However, I do understand that, it's about your bones and things like that, and we care for everything. But if you're not going to take the medication, and if you're only going to scream and harp and yell, you didn't think about it. We can't do both sides of this fence. We've got to decide which one you're going to land on. But we do have to start somewhere with education and awareness.
Absolutely.
Yeah. I was going to jump in here. I have very little experience in the HIV and AIDS space. The organization that I work for received a grant because of our interfaith approach and work. So we know interfaith well, HIV and AIDS less so. And so what does it look like to bring interfaith leaders to bear on this topic? But when we were doing COVID, to your point about going to the community, there were really low vaccination rates in the south suburbs of Chicago, and no one's really doing anything about it. The CEO of my org was like, basically, he does this all the time. He sends an article, there are things happening, let's do something. And so I found a clergy group, black clergy group in the south suburbs, 30 to 40 churches. They meet once a month around various topics. Asked them what they needed, right? What the barriers were, why you weren't doing it. And they're like, we don't have training, we don't have access, etc. So we brought the resources to them, and we were able to host clinics with them and to bring in black doctors who could speak to their congregation and connect them with black nurses who would be hosting those clinics. And so, but what we found, though, was that we were trying to educate and vaccinate at the same time.
Yeah.
And that wasn't effective.
Yeah.
Right? Because it feels as if you're pushing an agenda. It feels as if you're just trying to get us to take it. But if you come in and simply say, here's access to information, what that does is destigmatize the conversation, right? And also let folks know that if, in fact, you do decide at some point to learn more about it, we're here, right? And that has to be routine in order for them to even begin to discuss the possibility of even using the information. So it's a matter of like demystifying the conversation.
Yes.
And doing so with constant and ongoing educational opportunities. And then when they are in fact interested, you set them up to care, right?
Yep.
In sort of wraparound services type of way. So it's like, and so that's what I'm thinking about. Like educating and vaccinating at the same time is not effective. And so what does it look like to do? Like I'm really interested in the sort of marketing campaigns, right? Because so much of this is about narrative and is about framing. And I'm like, is there significant funding available for mass marketing campaigns? Is that something that the CDC or other government organizations are funding and putting money in and aren't just interested in, well, if we give you funding, you need to have this amount of people, right, to be interested in services. We need to reach this amount, right? Yeah. Where it's like, no. What you don't realize is it's the narrative work, right, that needs to be done. Yeah. And so I just wonder, like, is that something, this is my own, I'm new to the space, so I'm like, maybe that's out there. Maybe that's out there.
But you mentioned a key, your last few sentences, mentioned something that is extremely key. And when you bring in innovation, you cannot come in with preconceived metrics. We're finding out that initially the groups, whether they're religious, whatever they are, whether they're advocacy, whether they're pride groups, they want to start with their own set of metrics to prove their cases to us that it should be coming out. Here I am from the federal government, and I'm here to tell you exactly what. We got the completely different approach because we're boots on the ground, and we're doing it the other way around. We're not doing public health from a desk, and I know a lot of my colleagues get real mad, but hey, I'm out there talking to people.
Yeah.
Going to homeless shelters. I sit there. We share pizza. We share donuts, coffee, and you get people to talk to you, and you get to really. And that is the kind of information that we're sending out there immediately. Before we had so rigid and strict and what's the word, prescriptive that here are the stats, they've been cleared, they've been cleaned up. No, we want those anecdotal lived experiences to be counted, and that's what we're trying to achieve because we got to attack it from all different. I mean, in 2-3 years, whatever they're talking about will get validated by the data, but for now, we need to act on those testimonials, and that's part of the conversation that we have with our communities. And, well, by the time you find out, the numbers are just going to be up.
Yeah. I will say there's lots of funding in implementation science. So that's within the NIH, like a hub of like lots of recent support for implementation science, which is basically taking an intervention and figuring out how do we actually get it out there. So PrEP being the intervention, and like now we're learning, with very rigorous methods of like how to roll it out, which takes time, right? It's not like it. We have 2 different implementation studies right now. One with with Black women living in Mississippi HIV hotspots. How can we roll it out to them, right? But those results aren't going to be published for probably another 6 months, and that also 6 months of recruiting and analyzing all the other things, right? And then another one on teleprep, how can we roll out so PrEP delivered via telemedicine at community health-based organizations. So if you don't want to go in the clinic because you don't want to be stigmatized, okay, well you can go to a community-based organization if you don't have a computer at home, or you can do it and at home. So there's like 2 different studies.
And about PrEP, the other one that should be coming up should be incorporating the wraparound services.
Absolutely.
Because wraparound services, it's not like you're advertising PrEP, the lab, physical consultation, even transporting those lab specimens, whether the patient or the consumer has the opportunity to do their own site testing. Their 3-site testing over from the center. That all is going to make it more available, make it easier for administrators. That's my background, health administrator. I was running an HIV/AIDS clinic 15 years ago. I started with the CDC 34 years ago. So I've seen it. I've seen how it started, and I'm very happy that I'm now 180 degrees when there's opportunities. Because it used to be that we were out there in 1987 just telling people you are positive for HIV, and just look at suicide ideation.
Yeah.
Because people will, I'm not exaggerating. People will, they blow their brains because they started doing the stupid thing of notifying people over the phone.
Yes.
So the phone was there still. Yeah, and so there was no support. There was only ACT. But now I'm coming back, and there's this whole array of opportunities and resources, but we just need to get the right strategy. And engaging faith-based communities is key because they're enablers. They really have, they have a product that has been bought already, and they have a group, a membership that we need to take advantage of it.
What does that look like? What does that look like now in COVID? Because so many of the churches who were really just very active, though they have now become reactive because of COVID. But what does their work look like? Because a lot of them went to virtual, and are we back? Are we up and running more so, or what does that look like? Because in our area, we have on both sides. Some still decided not to open; they decided let's just do virtual. Where we still have some who are more active, but everybody has not come.
Anecdotally, from talking to Houston, Harris County, and Dallas County, and some areas of Louisiana, anecdotally, the biggest providers that made an excellent transition to telemedicine during COVID in HIV services because they kept 80 to 85% of their patients. I mean, they stay compliant. Not to say the same of testing.
But that was so funny. For us, our patients decided they did not want to do a virtual visit. They actually wanted to come in. I had more patients. I gained more volume of patients in my clinic.
That's a testimony that you're doing good services, providing good service. Because the patient develops a relationship with their providers, and they want to be there.
Yeah,
they want to be there.
And part of it was they now had time
Yeah.
to come in the door versus before they would have to take time off. But now it's maintaining them and keeping them in care, but they still, so we decided to do an evening clinic, and that's full versus during the day. So I'm having to make some decisions. Do I go evening or what do we do? But yeah.
One thing that you mentioned is like the idea that sometimes people want to learn about HIV testing, HIV treatment, and even PrEP, and then have some time to digest that information before making the decision of like, is this something that I want to do? And I think I just want to validate that is very real, and people do tend to be on the fence. So like, as someone who's done several PrEP interventions, so young men come in, I teach them about PrEP, tell them all the things they want to know, do some motivational interviewing, and then they say yay or nay at the end of it. Folks that knew about PrEP were much more likely to be like, you know what, maybe I do want to take this jump and try PrEP. Folks that did not, and they're like, this is my first time hearing about it, almost always said, you know what, I want to go home and do my own research. And what going home and doing your own research sometimes actually means is I want to go out and I want to, like, hearing their peers say that I've taken PrEP and here's my experience. It's not been that bad, right? Or I got on PrEP because of XYZ, or like being able to have those conversations with other folks, I think is so valuable. But I think the church is an excellent place to have those conversations. So, okay, great. You want to learn about it and then have some time to digest it. Well, the church can teach you about it and then bring you back next week to talk about it, and then bring you back again a couple weeks later to talk about it again, to keep the conversation going, to make sure they still know that it's on the table.
Yeah.
And also, maybe we can offer you, a site to host testing and resources, and hook you up with the nurse that's in the church that can tell you where to go if you want to prep a prescription.
And adding up, and I'll shut up.
Oh no, this is what the workshop sort of.
Adding up to that approach, ever since I worked running an STD and HIV program in the early 90s, we connected with student health centers for major universities and community colleges. And they also have religious services. Why not link them and provide that spiritual support and because they do it for reproductive health services, they do it for other services. Why not incorporate that, make it more comprehensive? So that would be one of the things that I would make a recommendation to Admiral Rachel Levine, that hey, let's incorporate that. Let's throw money into creating those collaborations and expanding our network, because it's like they keep saying, it's a whole society approach. That's the new national HIV strategy. It's a whole society approach. We need to do that. We need to bring them into it, and it's so valuable because faith-based institutions have credibility.
Yeah, they have power. I'm going to skip to a different slide. So they have influence over not just the people that are sitting in church with you, but also maybe that's somebody's mom who would benefit from a PrEP prescription. Maybe that's someone's aunt, sister, brother. There's so much influence there. And I love how you mentioned college institutions and how that can be an avenue. But I think the key is that there has to be a trusted social network, right, to get them in the door. So one thing that stands out is that when we were doing the intervention for PrEP uptake among young men, I was at JSU at the time teaching, and I had a young man who was part of the intervention coming in HIV negative, talked about PrEP, how it would be beneficial. He said, no, I don't want this. Fast forward like 9 months, he saw me walking around campus, and he came up and he said, hey, I'd like to can I get HIV tested? Could you help me get HIV tested? But he did not want to go back to the clinic. So I was able to show him where to go on campus to get HIV tested, but he went to someone who he had met maybe twice for the intervention, who showed that they cared, showed compassion, and that they knew what PrEP was. Right. And I think churches can be that person, right? Churches can be that like avenue to even college campuses, like collaborate, right? I know we mentioned community healthcare clinics, community-based organizations, but college campuses, they're right down the road, and usually they already have, like most colleges have
chaplains offices, religious affairs offices
already embedded in the college. So it's sort of
religious affiliation groups, just like the fraternities and
yeah.
And I think just one quick note, what you're stating and affirming in terms of what I said, I think aligns with empirical data as well.
Absolutely.
In marketing toilet paper, right? like people have to see an ad X number of times before they decide, oh, hey, I'm going to try this thing. Or, oh, when I am interested, I know who to go to or where to go. And I think marketing is just such a critical part of the work, and leveraging social media and influencers. And there's such a massive network of faith-adjacent social media influencers online who are critiquing the church, challenging the church for whatever reason, and they have massive followings. And folk who are interested in listening to them and hearing them, to people who have faith foundations, but they aren't necessarily in the church.
Yeah.
And so what we see is that it's not really the pastor that's having the influence, it's the social media influencer who's connected to faith-based institutions in some way, who have equal amounts of spiritual authority, because folks are scrolling through and listening to them for 3 or 4 minutes, and they like to follow their content and their information. And so I'm just thinking, like, how can we reach folk right, who may be faith adjacent as well. Spirituality is still important to them. They're still connected to, for example, the black church, but they may not be listening to that pastor because that pastor lost influence with them for whatever reason.
Yeah.
But there is someone else online that they listen to and are willing to sort of advance that work. I haven't seen a very robust campaign like that, particularly on social media or non-traditional faith-based spaces where I think those individuals have just as much power in their life.
Yeah. So what I'm hearing is it's hearing about HIV testing and PrEP from the right individuals, not just pastors necessarily. I'm always like first ladies. That's when I'm like, when black women in Mississippi said we want to hear from other black women, I was like, whoa, like what? That should be where we're going. Anyway, no, this is really. I love this conversation, and we only have 7 minutes.
Oh my goodness!
So
okay.
This is not new. So one of my mentors is one of the founders of Faith in Action. So I haven't heard of this organization come up. I actually didn't know that this existed until being invited to come be a speaker. When I got here, I was like, whoa, this is awesome. This truly embodies, like, you can be whoever and whatever you are outwardly here at this conference. And Faith in Action is, wouldn't necessarily describe it as far over in that way, but it is an initiative in Philly and in Mississippi where there are pastors who have gotten together and said, hey, let's take steps to ending the HIV epidemic. And those churches already have health fairs, HIV testing, and talk about the importance of HIV testing at church. So I only added this slide to mention that there are other organizations out there, and it's at some point I think it would be helpful for churches to sort of know. So like, is there a church in another area that's also doing something similar and having conversations about what are you doing that works, right? Or could we collaborate to host a revival, and this is included. We have a health fair with that revival, or Southern Gospel Show.
Easy, yeah, but it's just such an easy ask. I mean, you have these conventions and region-wide orgs, and yeah.
So let's see. Yeah, so this is summarized. I'm putting a bow on things. So these are the strategies that pastors mentioned. It's be knowledgeable about HIV treatment and PrEP. So pastors need to know these things. And clinics need to go to pastors to teach them those things. Be open and willing to address stigma and discuss HIV treatment and PrEP. And then normalize discussing HIV treatment and prevention. That's when I mentioned having people come in and tell their PrEP testimonials, is how I label that, or their, living with HIV and being healthy testimonials. And then create a health ministry within the church. I know that's been mentioned in several of the other presentations, but I do think that that's very important. And then these are just those things in detail. I want to make sure there's nothing else I wanted to mention. All right. This was part of a different activity that we're not going to get to. But the second part of the presentation that we didn't talk a whole lot about is making sure that how many of you are pastors or work directly with patients, or I'm saying patients, lingo, folks in the community? Most people, right? I think one of the most important things to, stigma is part of it. And also what stigma is eliciting is usually fear and anxiety about something. So how do you address that? We were going to do an activity, but we don't have time. But one thing I can say is connecting them to why they do. Like, why? Why go to the clinic? And that can be, for someone, it's because God wants me to be healthy. But for lots of folks, it's, I want to live a long life. I want to play with my grandkids. I want to, for every individual, it's different, but helping them connect to the why. And it's not always something as simple as, well, I want to, prevent myself from getting an HIV diagnosis. Okay, well, that's one reason, but why? Why do you want to prevent that? Or why do you want to, live and be healthy and take your medications for HIV? So connecting them to that. And, Jesus dreaded the cross, but he did not try to avoid it. He knew why he was going. So usually if we can be connected to the why we're doing something, and this stands also for like all that you're going to be challenged with connecting with people when you lead this conference to sort of get the ball rolling and things keep going. And I would challenge you and urge you to be connected to your own why. Why is it that you do this work? So, for example, when I think about my why for why started working with this community, I think of every patient that has ever walked in that door to be a research participant. And I get emotional thinking about that. That's my why. That's my why. Any last lingering thoughts, questions, concerns, or? Thank you all so much for coming. This was so great. It was a little different than I expected.
Yeah,
I thought I was
thank
going to
you
throw
for
some
sharing.
mental health stuff at you, but next time.
Thanks for sharing.
That's it was mental health enough. The sharing was good.
I have a follow-up question. So the Faith in Action boards that you mentioned, one thing that I'm thinking a lot about is that there are all of these coalitions and groups that have been created of faith-based leaders who are interested in COVID-19. How do we transition those relationships and connections to them now being the same folk we go to for HIV and AIDS, right? Or how do we get these folks to be the same folk we go to for LGBTQ plus advocacy, right? Or non-discrimination, as we think about social determinants of health and what makes one more likely or more at risk. And so I'm thinking about that org and whether or not they have been able to sort of, were they activated because they're already doing the work? Were they activated with COVID, right? And they were able to make that transition. And if so, what was that like?
Yeah. No, okay.
COVID has left several models or outreach or engagement models that we shouldn't let them die.
Absolutely.
We should hook up to them, and that's what we've been observing. Just like Affordable Care Act had those strategies to enroll into the Affordable Care Act, Medicaid, Medicare. We should just continue that, and this is the right time to start transitioning those models morphing those models into HIV, whatever else is there. So the necessity, the crude need brought that up. I think we need to jump on it and take advantage of it while they're still warm.
Yeah, I agree.
No, the pastor said that. We didn't have time to discuss it, but COVID-19, because we sort of did it in the middle. So probably focus groups were done like a year and a half ago-ish. So COVID had already, it was a thing, and people had just started going back into churches. And that's what they said, like, let's use the momentum. We're talking about COVID-19, which a lot of people already are relating to HIV. So when they're like, well, how do you have a vaccine for COVID, but you don't have a vaccine for HIV yet? So let's use that to start the conversation up again about HIV.
Right.
Whether it be treatment or prevention.
Yeah.
Thank you very much. This
This is very helpful.
Yeah, you're another resource for us because we keep bringing innovation. We don't want to be boxed into prescriptive orders from the rebels for the Surgeon General, and we say, hey, you cannot bring boxes or check marks on anything that is going on. We need to start listening to what's going on and bring it up because if we wanted to continue to be 38,000 new HIV cases a year, that's going to stay like that.
Yeah.
But if we don't bring somebody else into it, we're never going to get to the goals. Anyway.
Another question, this is really inspired by a comment that you made, particularly around funding. So I'm thinking about the sort of barriers that exist for community organizations, community-based organizations, to be able to carry out this sort of work. And so outside of the NIH and even Gilead, that's doing a lot of the work, are there sort of other opportunities that exist?
Yeah, absolutely.
And where is that?
Yeah.
Right, how do you get access to that information, amplify that information? Because it still feels to me that there's some folks who are in the in-group and know, right, what that funding is, and they sort of get granted again and again, right? And then there are other organizations that aren't aware of those funding sources. So I'm curious to know.
That's an excellent question, and I would argue that no one is an expert on every source of funding because there's so many different ones. So like most of our funding comes from the NIH, and I will say that you could probably, one idea is to reach out to folks who are doing research in the area. For example, one of my mentors, Amy Nunn, is over Faith in Action, which is housed at Brown University, however, in Mississippi and Philly and other areas. Other thing to think about is someone mentioned there are lots of foundation grants. too many for us to like go naming off, and to consider health insurance companies usually have like a pocket of money for things like this that they are usually trying to find people to use. I have a friend who works for, I don't know if it's Blue Cross Blue Shield or United Health Insurance, but she was like, we have $100,000 that we're just trying to find people to give it to, that, and the only requirement was that they could say, like, I'm helping the community in this way. I'm giving them this. Or like, I'm gonna buy like, health monitoring bracelets for everyone in my church, and we're gonna just monitor our health for a month. That was it. It wasn't like we had to do a project or anything. It was just a resource. So reaching out to different healthcare and ask around. So like, if you know a church that got money, then well, how else, how can I get money?
There's money.
Yeah.
There's
Right.
There's money.
HRSA is the other sister agency that has a lot of funding, and for the last 5 years they've been putting out there about $100 million to incorporate faith-based mental health services. HRSA, Health Resources and Service Administration, and so is SAMHSA now with harm reduction.
I was gonna say
SAMHSA and CDC, obviously. Surprisingly, HRSA is HRSA, and that's what we're trying to do. We were the Office of Secretary of Health, so we're a little bit over them, so we can have direct contact with the Assistant Secretary of Health. And that's why we've been able to change the funding strategy. And we are trying to incorporate those bridges in between, whether it's your different missions, or different, approaches to outreach. So we're trying to bridge them and bring the money where it's supposed to. Like supporting smaller not-for-profits that they don't have this infrastructure, that then we can get into a bigger community-based organization that can maybe mentor them or provide, whether it's fiscal sponsorship, so get them started and then reward collaboration instead of creating competition. I can tell you that here in the Dallas area, instead of bringing together, sometimes it's creating a lot of animosity and enemies.
Yeah.
So that's part of the challenge too, that be fair to everybody and be inclusive.
The other thing that as a researcher is, and it was on a slide, is talking to your congregations or folks about being open to engaging in research. So we do lots of studies, and we're always recruiting participants. And sometimes those interventions, like a lot of the men said no whenever we did the brief prep intervention, but they left there after talking to someone who showed that they cared about them. I always had candy on my desk, and sometimes they'd come in and hadn't eaten, and they left with money in their pocket, right? And that, it only benefited. They were educated, and now they knew about PrEP to go talk to other people about it. So being open to reaching out if you see that someone's doing research on a population that goes to your church or is in your community, like reach out and be like, hey, you need another recruitment site, and everyone wins from it.
Yeah, I'll give you a lead. If you work with minorities, between the MSN males, MSN males, between the ages of 18 and 34, you are almost guaranteed that you will get some kind of money. Believe me, because that has been our priority population.
I'm recruiting that population right now. So.
Yeah,
Yeah.
And the other of our population, we've got a great deal of money out of it.
And best utilization of social media to outreach.
That's
the key.
That's how we did it. And so I do work with Interfaith America, but I also do work with an organization called Pride in the Pews, and we specifically work with particularly straight identified Black pastors to educate them around LGBT inclusion. But what that also means is we've attracted a lot of Black LGBTQ plus Christians, right? Who come for social gatherings and events, and we've been able to connect with faith leaders across various sectors who are interested in this conversation. And so, we have folks who are coming to our events and showing up, and usually we're just fellowshipping or sharing resources around topics that we're interested in. HIV is not one of those, all right? And so I think that there's a real opportunity, because also I'm younger, I'm the face of the organization, so I'm recruiting people who are my age and who are interested in this in the way that I am. And so I feel like there's opportunity, right? But thinking about where, now I'm named the public places, very concretely, where funding might exist to actually build that out.
there's always, we talk to a kind of a seasoned grant writer, there's always that opportunity of having an unsolicited request for funding. And you work those out through your representatives. Because I know there's not an RFO, request for proposals, but here, that's what I want you to do for us. And I would represent the zip code here, or even get more granular than the zip code. 5 blocks have a lot of, like here in Oklahoma or North Texas, opioid crises that need to be, paid attention to it, and they do that with an unsolicited funding request, and you can do it. And normally you take it to your politician, and they should do that for you. You're giving it the entire work to use their power to. Obviously, it's no, I don't want to support HIV and AIDS. No, then find the right one.
That's right.
That's an unsolicited, and that's how I got. When I was running that HIV/AIDS clinic over in El Paso, which is Southwest Texas, border New Mexico and Mexico, I had a $25,000 worth of county funding that I always competed for. But getting that little money opened the door for me for so many things. It opened it up for the city council to pay attention to us, to know who we were. So when we asked through a 501c3, we asked for a building donation to us. We got it because they know who we were,
Right.
and those $25,000 opened up the door. So how creative you get is really, there's no limit. The need, donations, individuals that donate funding, they need to know who you are.
That's how we've gotten the funding that we've gotten. It's through, to your point, those relationships, and the small grants led to bigger grants, and et cetera. So that's, I hear that, and I've also seen it work well. It is true.
So, I love what I do. I'm very happy. I'm back to where I started back in '87, back to HIV and AIDS. This is quite rewarding that I started when there was nothing, literally nothing. The last 3 years.
Yeah, that's hard.
But anyway.
Yeah, thank you so much.
This has been such a great discussion.
Yeah.
Thank you all. I was at the gym this morning, and someone said, "Go give them some information." I said, "I'm going to give them some information and get some information." And that's success.
Can I give you my card?
Yes,
See, maybe
thank
we can
you.
bring you over. We put you over for some.
I would love that.
Over Region 6, we got Texas, Louisiana, New Mexico, Arkansas, and Oklahoma.
So, as mentioned, I'm an Arkansas native, and at some point would
Then
love
you
to
should
start
pay
doing
attention
some more
to my
work.
Information. And we're visiting Arkansas in 2 weeks.
Oh, what part?
We're going to Little Rock initially, but we're going to take the tour and see meet people where they are.
Okay.
We don't stay. We don't do just the the health authority, the public health department. No, we really get into it.
One of the things that one of the studies we had done was on looking at HIV hotspots, but not like where people are living, but where HIV transmissions are actually highly to be happening. For example, so folks traveling from the Arkansas to Memphis to party and play, and then traveling home.
I call them epidemiological corridors.
Okay. Yeah.
That's my coined phrase because we have Austin, San Antonio, and Houston, and then we got another one with Dallas, Oklahoma, and Arkansas. So those three, because even for service prevention people,
They even check the evaluation survey. This is on the app. Let's see, remind everyone to take the evaluation survey. So,
Everyone's taking the evaluation.
that's all that- that's what I done.
another good predictor of HIV incidence is going to be your STI. Texas is having a syphilis crisis, and in a few months or maybe a year or so, we're going to see this higher correlation with syphilis. So
comfortable at, right? When they come in and they're sitting there, they're like, well, statistically, that might be a great option. Thank you so much for considering. With the, yeah, I had a meeting during lunch, so I had to go to my room on a telehealth call. So. Yeah. I understand.
I gotta do something about it.
Someone's calling or someone forgot their phone was
That's,
here.
no, it's one of the guys that's going
Oh,
to live stream.
okay. Someone keeps calling you.
Teresa, right?
Yes.
Yeah, Teresa.
Remember, they forgot the R.
Yeah, that's it. Okay. Yeah. Well, your email's good, then, isn't it? No one contact you? Okay. Yeah, I'll send you an email. Something. I've always wanted to.
Summer's the best time to visit.
Oh, yeah.
The weather.
Yeah, are you all, is it Newport on that?
That's about an hour from us. But yeah, Newport's beautiful. They have the mansions and stuff.
Sailing, yes.
I'm not done sailing, but the mansions are, that's usually what we take people. If someone comes to visit, I take them to Newport to see the mansion.
You do.
It's like a staple thing. I don't know. Yeah. That and you get some New England Planet Tower.
So coming to Newport, but who flies up here? Where do you fly in?
Providence.
Oh,
Yeah.
okay, so the Rhode Island University, then the Providence, the Flyers. Is that
No.
the same? Am I
So
thinking wrong?
Rhode Island and then Providence and Newport are in Rhode Island.
Right, but I'm saying those two universities are.
Oh, there's a couple. There's Brown University, which is where I'm at. There's Rhode
Browns
Island
in
College.
Browns in Rhode Island.
Yeah.
Okay, that's where you were still you came up with.
I'm a assistant professor there
Okay.
now. Yeah.
How often are you teaching?
I'm just doing research, so
Oh,
it's
I
assistant
got
professor
you.
of research in
understand.
small bracket.
I'm trying to.
Yeah, I did a little teaching at Connecticut College just as like a side gig, but I don't really have as much time for it right now.
Oh,
I'm
my
trying to focus on clinical work.
So, yeah, there's that. I'm trying to find, I don't know what we're doing. Maybe this week.
I think they're actually, we may be missing something, I don't know.
No, they're not in that big room. No, they just finished up.
Oh, it may
Oh, I
be,
think you have a break.
yeah, maybe a break until.
You have a break until dinner, right?
I'll check. I feel like sometimes I gotta check the other calendar, because this one don't always say.
I'm afraid to take a nap. I mean,
You may not wake up till tomorrow.
yeah.
Let's see.
Yeah, I think we're.
Yeah, I don't see any other sessions
Yeah,
tonight.
that lunch. Oh, God. I thought it was wonderful. Did you have lunch now?
No, I had a meeting, I missed it.
Oh, lunch.
Yeah.
I'm telling you, that lunch was really.
No, I'm not seeing them. We'll bring up the schedule real quick.
No, they just said take summer. She did the thing. Yeah, 6:30 is the next. Break. Yeah, so we're on the break until.
Break, 4:30 to 6:30. Oh no, there's a media thing at 3:15 to 4:30. Where did I turn that?
It'll be over in the bar, over here. I think they already done it.
Oh no, it would just be starting, because it's just now 3:16. And then break from 4:30 to 6:30.
This is, where's that? It's in the big one.
Led
But I done seen you in
virtually.
there.
Oh, it says led virtually. So it may be that you have to log on. I don't know. But dinner's at 6:30. More importantly. I want to come back for food.
I just hope my flight goes well tomorrow. There's no stuff. Because I need to get home. And then just get going.
Okay, we don't want to be streaming this